Not, then move on to the next talk by Mahesh from Kochi on cardiac MRI. Why should I do it in PAH?
Thank you very much, PCSI, for this opportunity to present at this forum. And I'll be speaking on why I should be doing MRI in pulmonary artery hypertension. So in the assessment, diagnosis, and in prognostication of pulmonary hypertension, so the important elements that we look at in any case, including this particular case in discussion, are number one, the pulmonary vasculature, which includes the anatomy, pressures, and the flows and resistances. And the second important aspect is the right ventricle. With pulmonary artery hypertension, there is compensatory RV myocardial hypertrophy, progressing into contractile dysfunction, ventricular dilatation, begetting tricuspid regurgitation, worsening RV strain, and also RV structural microstructural damage, which includes fibrosis and scarring, and eventually decompensated RV failure. And so the RV health is an important indicator of PAH severity and chronicity, and an important determinant of life expectancy and predictive of the mortality, as well as the success failure of the therapeutic regimens. Yet, most imaging modalities are limited in their ability to assess the right ventricle, and this is one of the areas where cardiac MRI really comes in. Also, when we deal with congenital heart disease PAH, there are multiple special considerations which include the complexity of the anatomy and the hemodynamics, and the associated difficulties in decision making. So the challenges also are that the patients are often older and bigger, like this particular patient who's 28 years old with probably difficult echocardiographic windows. And these patients need repeated assessments almost lifelong. And PAH is a strong case for multimodality assessment, as has been revealed in the preceding talks as well. And you also need accurate, consistent assessments as crucial parameters for tailoring the management of these patients. So cardiac MRI as a generic strength, it brings several things to the table. It is a non-invasive comprehensive assessment modality which is multiplanar and volumetric and is made up of multiple sequences which offer anatomical, structural, physiological, and flow information. It is a modality with excellent resolution and tissue characterization ability, and it is amenable to serial evaluations with excellent inter-observer reproducibility. It complements, completes, and validates the information obtained through the other modalities. So if you look at the wish list of the things that you would like to assess in a case of PAH, it is a comprehensive assessment of the RV, including volumes, ejection fraction strain, pressures, stroke volumes, mass, etc. The assessment of an RA and assessment of the pulmonary arteries, including the distensibility, hemodynamics, and quantitative lung flows. And MRI is able to provide information on most of these aspects, except for where it requires pressure assessments. MRI falls abysmally short when you talk about pressure assessments. So first is assessment of the right ventricle. The MRI sequences, particularly the 2D SSFP CNA sequences, are the gold standard in the assessment of the RV volume, mass, and systolic function, and the workhorse of RV functional imaging. So this is a bright blood sequence where you take multiple cardiac phases of a single cardiac slice in one breath whole time, and you can contour the myocardium in the end systole and end diastole to get precise measurements of the volumes, ejection fractions, and the ventricular output. You can also get the RV myocardial mass and the RV-LV mass ratio. You can visualize the tricuspid annular dilatation and the regurgitation, and all this is with excellent inter-observer agreement. This modality is ideal for serial measurements of the RV health, and now it is also possible to do real-time acquisitions. The interventricular septum is an important indicator of the pulmonary artery hypertension because in accordance with the RVSP and the LVSP ratio, the bowing of the interventricular septum is a good indicator of the elevated RVSP. The paradoxical septal motion can be seen very clearly on the 2D SSFP sequences. Not only can you see these images, you can also precisely measure the interventricular septal angle on these sequences and use formulae based on the ratio of the curvature of the interventricular septum to the curvature of the LV free wall to get a reasonable estimate of the RV systolic pressures. The RV myocardial delayed enhancement is indicative of the tissue abnormalities or injury or fibrosis that occurs with pulmonary artery hypertension, and this can be detected as the delayed enhancement on delayed gadolinium enhancement sequences, characteristically at the RV insertion points extending into the interventricular septum. And the extent and volume of the delayed enhancement is inversely proportional to the measures of the RV systolic function like ejection fraction, stroke volume, and the stroke and the stroke volume. Recently, there has also been interest in the assessment of RV diastolic function by cardiac MRI, including the assessment of the RV isovolumetric relaxation times and the RV filling rates, both the early and the late filling rates. There are newer tools in the assessment of right ventricular assessment, include the RV strain imaging, which is a family of sequences which involves setting saturation grid lines across the heart and studying the deformation along with the ventricular contraction. And when you combine this information with cine imaging, it provides wonderful information on myocardial strain, shear stress as a volumetric information. It is more sensitive than ejection fraction, particularly when you talk about regional changes in function, and can be a good predictor of outcomes. The RV radial strain has been associated with the RV PA coupling and the RV longitudinal strain with the RV end diastolic stiffness. The RV T1 mapping goes one step beyond the delayed enhancement sequences and allows a quantitative assessment of the diffuse interstitial fibrosis in the right ventricle. And there has been found a significant association between the RV insertion point T1 time and the LV eccentricity or the IVS angle. And RV free wall T1 correlates with end diastolic RV stiffness. Coming to the assessment of the pulmonary vasculature, this is a very important aspect of evaluation of any PH patient, and MRI offers excellent anatomical visualization of the pulmonary vascular anatomy. You can use the gadolinium enhanced angiograms as well as non-contrast sequences to assess the anatomy. Black blood is another sequence that can be used. The Cine 2D SSFP sequence allows you to visualize the distensibility of the proximal pulmonary vessels very clearly, and you can make accurate measurements as well. The anatomical assessment also allows you to detect the presence of intracardiac or intravascular thrombosis and deposition of iron, for example, as Dr. Vimal pointed out in his previous talk. The assessment of flows is one of the biggest advantages of cardiac MRI, and the phase contrast sequence on MRI is a gold standard for assessment of blood flow and can provide a wealth of information on the volume of flow, regional and segmental flows, the characteristics of the flow, and also can be used to derive various indicators for pulmonary vascular resistance. You can obtain information on peak, maximum, minimum, and average flow velocities, and a host of derived correlates, which include PA distensibility, acceleration time, ejection time, etc., have been used by various authors in understanding, characterizing, and describing the various aspects of pulmonary hypertension. And even looking a gross visualization of the flow time graphs across vessels with different levels of pulmonary vascular resistance, it gives you a visual estimate or a visual estimate of the pulmonary vascular resistances. Recent developments like 4D flows, which is a newer tool, allows for volumetric assessment of complex 3D hemodynamic and flow changes, and you can qualitatively assess the altered flow in the form of vortices and helices. You can quantitatively measure wall shear stress, vorticity, and pulse velocity. And pulmonary artery hypertension has been found to be associated with abnormal vortices. And various regression equations have been formulated, which are based upon all of this information in estimating pulmonary vascular resistances. Cardiac MRI is also incredibly useful in treatment selection and monitoring of patients. You can actually actively assess vasoreactivity by looking at PA distensibility and RV stroke volume after administration of a vasodilator element. And you can also monitor the change in an array of parameters over a period of time while the patient is on treatment, and also offers information on the cardiac remodeling. And multiple evolving cardiac MRI-based tools also include exercise MRI in the assessment of ejection fraction, cardiac output, and pulmonary artery flows, MRI perfusion imaging of the lung parenchyma, hybridizing MRI with catheterization to provide MR-guided catheterization procedures. And now with the development of technology, deep learning and AI-based predictive models are also becoming increasingly available. So if you look back again at the checklist that I previously showed, MRI is very useful in most of these parameters, except wherever there is pressure measurement involved, where MRI can only provide you derived measurements and no direct measurements. This is an 18-year-old patient probably similar in characteristics to the patient in the question, where we have an anatomical assessment where we are able to see a comprehensive anatomical assessment of this patient having a single outflow, and the angiogram showing that the patient has MAPK-derived pulmonary blood flows with a MAPK going into the right lung being stenotic at its origin, and a MAPK going into the left lung being unrestricted. In this angiogram, you're not only able to see the anatomy, but you're also able to see the pulmonary vascularity. You can see that the lung with the unrestricted pulmonary blood flow shows evidence of increased pulmonary vascular resistance, whereas the pulmonary vascular bed is much more perfused on the right lung, which has a restricted MAPK. MRI allows you to quantify the blood flows into each of these segments, not only in terms of the quantity of the blood that's going into these lung segments, but also the flow characteristics. And together with that, it also provides the ventricular parameters, the ventricular volumes, and the functions, which also allow you to assess the patient's clinical condition. So MRI has its own limitations. It is expensive, it is expertise and infrastructure dependent, and the pressures and resistances still remain complex derivations, which are still awaiting validation. The distal vasculature anatomical assessment is suboptimal as compared to CT scans or digital subtraction angiography, and there are several contraindications to MRI in itself. So why should I do MRI in PAH? It offers a comprehensive, non-invasive array of tools for detailed assessment, for primary assessment, as well as for repeated measurements. It complements the information from other modalities and is of particular value in CHD-PAH. And it can provide unique pathophysiological and prognostic insights into PAH and serve as a guide to treatment. And the technological advances in the form of AI, etc., are sure to yield newer tools and unveil newer information. Thank you.